When complications arise, perinatal morbidity and mortality risk increase. Now, some complications are anticipated, such as when a mother is identified as high risk. Other times, the complications are unexpected or unforeseen. Because of this, it's crucial for nurses to understand a normal birth process so that they can prevent or detect deviations from this normal labor and birth pattern. They will need to implement nursing measures if complications do arise, and the nurse and the entire OB team must use knowledge and skills in a concerted effort to provide care in the event of said complications. Approximately 12% of all live births are preterm, and approximately 75% of all preterm births are classified as late preterm because they occur between 34 and 36 weeks gestation. Preterm birth and prematurity describes the length of gestation, regardless of what the birth weight of the neonate happens to be. So if you have a neonate that's delivered and it weighs less than 2,500 grams, that neonate is considered to be low birth weight. However, it may not necessarily be preterm. A fetus who is diagnosed with IUGR or intrauterine growth restriction will be small, but it still may be a term pregnancy. For what should be obvious reasons, preterm birth is more dangerous to the infant due to the decreased length of time it spent in utero, which will correlate to immaturity of body systems. Preterm births have been categorized into kind of like two triggers. It can be either a spontaneous or an indicated trigger. Conditions that cause preterm labor and or preterm birth will include preterm labor with an intact bag of waters, preterm premature rupture of membranes, an incompetent cervix, or infections such as amnionitis. Remember, sometimes the fetus is going to do better outside of mom than in. So a preterm birth may be the best option to increase maternal and neonatal outcomes. Indications for preterm births will include preeclampsia or eclampsia, placental abruption, IUGR, renal disease. You've got to think about the amniotic fluid and the potential for oligo, pregestational diabetes, isoimmunization, or congenital abnormalities. When trying to determine what risk the mother has for preterm labor and preterm birth, first look at what you know. Has she ever had a preterm birth? Has she had preterm labor? Is the current pregnancy a multifetal pregnancy? Did she experience bleeding after the first trimester? Does she smoke or have other risky behaviors? If you're going to look for things, well, look at your biochemical markers. Your fetal fibronectin is a glycoprotein that's usually seen in early pregnancy and then again in late pregnancy. So if you have a concern for preterm labor or birth, you can do a vaginal cervical swab to collect fluid, and what you're doing is looking for the presence of the fetal fibronectin. If you see it, it does not reliably predict that the woman will experience preterm labor or birth. However, the absence of it has been used to determine that she's not going to go into preterm labor. So it's really more to say who is not at risk than who is at risk. Cervical shortening with preterm labor actually occurs over a period of weeks. So just looking at, the cervical length may not be an indicator of preterm labor, preterm birth. Again, kind of look at the flip side. If her cervical length is greater than 3 centimeters, that individual is not likely to go into preterm labor. So what causes preterm labor and birth? What do we need to look for? What do we need to be aware of? Right now, infection is pretty much the only definitive factor that we know of that causes preterm labor and birth. If you think about it, we talked in the previous lecture about pyelonephritis being a reason for hospital admission and observation because pyelo puts her at a risk for preterm labor. Another theory is that early bleeding, first or second trimester, can lead to uteroplacental ischemia or hemorrhage, which can, put the pregnancy at risk and would cause a preterm labor. What we are beginning to see and understand is that preterm labor and birth may have many different associated triggers and processes, things like a multifetal pregnancy, polyhydramnios. Those two things work together and can cause overdistension of the uterus. In conjunction with each other, they can all lead up to the potentiation of a preterm labor and birth. The good news with all of it is that current research has demonstrated the use of progesterone, especially if you've got somebody who has a history of preterm births. You can start giving the progesterone somewhere around 15, 16 weeks of pregnancy. The injections, their IM, usually last through 35 weeks of the pregnancy, and then they'll stop and let her just go into labor whenever her body goes into labor. But the injections have been shown to reduce recurrences of preterm labor and birth pretty well. Now, all women are at risk for preterm labor, but some are more at risk than others. If you have risky lifestyle behaviors, the woman needs to stop them, okay? So no smoking, drinking, drugs, no unsafe sex practices, thinking about the STIs that she may have. If she has a pre-gestational or a gestational condition, make sure that she is adherent to her treatment regimens and instructions. All women will need education as to what to watch for that could indicate the possibility of preterm labor, such as a contraction pattern that is painful contractions and they get stronger, longer, closer together, or if she's experiencing more than 6 contractions in an hour. If she is having contractions, tell her to go to the bathroom to void, empty her bladder, have a little something to eat and drink, lay down on her side in a nice quiet room, and just observe what the contractions do. If the contractions slow down and resolve, it's all good. If not, she needs to notify her care provider day or night, doesn't matter what time, when it is, she needs to call. So she can call labor and delivery or the office. The unfortunate thing is women sometimes wait too long to notify anybody, and a preterm labor that may be stopped with instruction progresses to a preterm birth simply because, she doesn't understand what's happening and what the significance of what's happening may be, and that the contractions she is experiencing are not always a normal event. The diagnosis of preterm labor is based on 3 major criteria. It will occur between 20 and 37 weeks gestation. You will look at the contraction pattern, and you will look at cervical change. You should be seeing effacement of 80% with dilation of 2 centimeters or more. Just a little side note, if the fetal fibronectin is going to be assessed, for seeing if it's present or not, make sure the sample is collected before you do the cervical check, because the lubricant that is utilized to do the cervical check can alter the test result. Now, the woman who experiences preterm labor will need instructions for, after assessment in the hospital, because she's going to need to try and prevent the progression to preterm birth even further. In the past, previous lectures, we talked about bed rest, and that may not be the best intervention for your, pregnant female. However, there are still providers who will recommend bed rest in this situation. Now, strongly limiting activities and work is very likely to be advised. If symptoms of preterm labor, such as contractions, occur after sexual activity, or more specifically orgasm or nipple stimulation, and this happens after 20 weeks of gestation, then sexual activity is off the table until she's at least 37 weeks. Because if she has preterm labor and then you're going and potentiating it with the oxytocin, we're going to have preterm birth. So for the woman who has restricted home activities, think about what she's limited with, okay, and make her environment as conducive as possible to, limiting movement and excess ambulation. So, kind of bring the things that she may want or need closer to her. Now, she will still be more than likely allowed bathroom privileges. She can get up and get a shower and stuff like that, but she just doesn't need to be doing extraneous activities. If you look in your book on pages 680 and 681, you got two really good tables there that review the nursing responsibilities for the patient that's in preterm labor. If she is in preterm labor, we want to stop the uterine activity, which best case scenario will stop the progression to birth, but at the very least we want to delay birth long enough to institute interventions to minimize neonatal morbidity and mortality. To do this, we're going to use a class of drugs called tocolytics. These include magnesium sulfate, beta-adrenergic medicines, calcium channel blockers, and NSAIDs. All right, so MAG, we've already talked about your hypertension, but we're going to talk about it again because it's also used in preterm labor. So MAG is going to promote smooth muscle relaxation, but there's a lot of risks that are associated with MAG toxicity. Dosing for MAG is going to be the same as with preeclampsia or eclampsia. You're going to get a 4 to 6 gram loading dose, usually given within 30 minutes, and then you're going to have a maintenance of 1 to 4 grams an hour. Your terbutaline is the beta-adrenergic. It will relax smooth muscles as well, but it can also trigger bronchospasm or tachycardia. Because of this, if you're given TERB, you need to check the mother's heart rate first. It should be less than 120, and make sure that she's not an asthmatic. TERB is dosed 0.25 milligrams subcutaneous Q4 with treatment lasting no more than 24 hours. Your calcium channel blocker, nifedipine, it stops contractions by blocking calcium from entering in the cells. While no ideal dose has been determined, typically the starting dose is going to be 10 to 20 milligrams PO every 3 to 6 hours until the contractions are few. Then you'll go to 30 to 60 milligrams every 8 hours for 48 more hours. You want to avoid nifedipine with or right after the administration of terbutaline, and you don't want to give it at the same time you're giving MAG. Your indomethacin will promote uterine relaxation by blocking the activity of prostaglandin. Remember, prostaglandin causes smooth muscle contraction, so the indomethacin blocks that. The dose of this is 50 milligrams PO followed by 25 to 50 Q6 for 48 hours. Steroids are indicated when preterm birth is expected and the fetal lungs have not reached maturity. In the neonate that's delivered between 24 to 34 weeks, immature lungs yield a very high risk for respiratory distress at birth. Keep in mind the use of steroids for advancing fetal lung maturity is not FDA approved, so we use these in an off-label capacity. The dosing for the steroids is listed in the slide. Your betamethasone, also known as celestone, is 2 doses, 12 milligrams IM, given 24 hours apart. Your dexamethasone or Decadron is 4 doses of 6 milligrams given 12 hours apart. So each therapy is going to take about 48 hours to complete. Even though antenatal steroid use is off-label, the National Institute of Health recommends treatment for all women at risk for preterm birth. Promoting fetal lung maturity reduces the incidence of respiratory distress syndrome, necrotizing enterocolitis, intraventricular hemorrhage, or the worst case scenario, death. Nurses need to be pretty well versed in the management of these patients. Understand that a labor progressed to a dilation of 4 centimeters. 4 centimeters may very likely lead to an inevitable preterm birth. The woman may rapidly progress through labor, and you got to think about a very small fetus, depending on the amount of prematurity that it is, can go through a cervix that's not fully dilated. So you may even have the possibility of a vaginal delivery of a breech presentation, which is much more likely in a preterm birth than a term birth. Okay, but in light of all of these concerns and how quickly things can progress, nurses really need to be able to handle emergency deliveries should the need arise. Membrane rupture at less than 37 weeks is responsible for 1/3 of all preterm births. Now, premature rupture of membranes is defined as the rupture of the amniotic sac and leakage of amniotic fluid beginning at least 1 hour before the onset of labor at any gestational age. It does result from a pathologic weakness in the fetal membranes. And chorioamnitis is the infection of the amniotic cavity and is the most common complication of premature rupture of membranes. The premature rupture will generally transition to labor if they're at term. And if their term is they ruptured and labor doesn't start on its own, then they'll induce her. In a premature preterm rupture of membranes, we want the fetus to stay in for as long as possible to get fetal maturing, okay? If you see bleeding, if you notice fetal distress, placental abruption, or signs and symptoms of infection, then even with a preterm premature rupture of membranes, we're going to go ahead and deliver. However, if there's no need for immediate delivery, if she's ruptured or leaking but the baby's stable, we're going to conservatively manage her. We're going to observe the fetus with daily NSTs and BPPs. She is going to be monitored for preterm labor, infection, and the possibility of a placental abruption. To prevent chorio, because chorio is, the most common complication, we are going to give her a 7-day course of broad-spectrum antibiotics like ampicillin or erythromycin. Dystocia is defined as a long, difficult, or abnormal labor. Without adequate and functional uterine activity, you're not going to see a normal labor progress with cervical dilation, effacement, and fetal descent. Factors that increase the risk of uterine dystocia will include maternal age, any uterine abnormalities, if she has had too much exposure to oxytocin, if you have cephalopelvic disproportion, or CPD, if she gets her epidural too early, if she doesn't have a very effective established labor pattern, or if she gets analgesias too early, that can actually slow the labor down. The fetal presentation, position could affect it, and the mother's size. If you've got somebody who is short, overweight, not a very long torso, then they are at risk for having a a labor dystocia as well. Abnormal uterine activity can further be defined as hypertonic or hypotonic. In hypertonic dysfunction, contractions may be overly strong and or frequent, and the uterus may not return to a soft resting tone between contractions. In response, the laboring woman may be very afraid, feeling out of control about what's happening, and she can get exhausted. Interventions, therefore, such as therapeutic rest and good pain control, can be utilized to minimize any negative outcomes. Hypotonic labor is pretty much the opposite. When the contractions may start off in a normal pattern, but then they change and they just aren't effective or frequent enough to continue cervical change. So you just kind of stall out in the labor. Your cephalopelvic disproportion and malposition are other common causes of this. If the woman is not effective with her pushing, she may not be able to complete a normal labor and delivery, and assistance with either forceps or a vacuum device may be needed. Or if it's an urgent delivery, if we start seeing fetal distress or anything, then we may need to do a cesarean birth. If you look on table 22.1 in your text, that's on page 691, you will see the 6 abnormal labor patterns that result in a labor dystocia. Now, the one that you should be familiar with is your precipitous labor. I mean, you've already studied this and done some remediation on it. What you need to remember is that with your precepts, the labor progresses very quickly. Generally, it's going to be less than 3 hours from the onset of labor through birth. Associated causes include placental abruption, hypertonic uterine contractions, or sadly enough, cocaine use. Pelvic dystocia can occur when contractures of pelvic diameters reduce capacity of the bony pelvis, the inlet, the mid-pelvis, or the outlet. Your soft tissue dystocias results from obstruction of the birth passage by an abnormality that's not the bony pelvis. I mean, you may have a low-lying placenta or uterine fibroids. Occasionally, cervical edema will occur. If the woman starts pushing too early, if she's not complete, then obviously you can stress the cervix. You can have some swelling there. Fetal anomalies, your neural tube defects, specifically like a myelomeningeocele, or you may have a gastroschisis. Either of those can cause a dystocia with your labor. If you have fetal macrosomia, then the dystocia is a fetal cause. If the pelvis is too small or misshapen or it's deformed, it's a maternal cause. So CPD, we say cephalopelvic disproportion, but it's also referred to as fetopelvic disproportion. And that may be more accurate because the size of the fetus and the maternal pelvis aren't compatible with each other. So with CPD, it can actually be a fetal or a maternal cause. OP, your occiput posterior, is the most common malposition to cause labor dystocia, with about 15% of all fetuses in this position at birth. If the fetus is presenting in any way other than cephalic, so other than head down, it's malpresentation. Now, breech is the most common malpresentation, and you've got 3 categories. You've got frank breech, complete breech, or footling breech. Complete breech is just the normal really fetal position. You know, the knees are bent, the hips are flexed, the arms are crossed over, head's tucked down. It's just upside down. So instead of the head coming first, it's the butt coming first. In a frank breech, the legs are fully extended. So that's the difference there. And then a footling breech is where a foot is coming out first. If you look at figure 22.3 in your book on page 693, you'll actually see an image of each type of breech presentation. Now, breech is usually identified with vag exams, and then it's confirmed with ultrasound. Vaginal delivery of a breech presentation really shouldn't be done unless it's absolutely necessary, because there's a lot of risks associated with it. Some things, a prolapsed cord. You may have maternal trauma, fetal trauma, or even fetal death. So it's going to take a knowledgeable and skilled practitioner to successfully complete a vaginal breech delivery. Now, other malpresentations include a shoulder presentation or a face and brow presentation. If your mom is not allowed to change positions while she's in labor and she's forced to stay in bed or even stay on her back, well, you got to think about it. The fetus isn't going to rotate and descend very well. And if the labor maybe is prolonged or she's in a lot of pain, anything that can cause stress or anxiety to the mom will trigger catecholamine releases, and the catecholamine release can affect a labor dystocia by reducing uterine contractility. If the woman is a multip and breech, the provider may attempt a version or a rotation of the fetus into the cephalic presentation. Versions are typically done after 37 weeks and usually in labor and delivery. Terbutaline is often given to promote uterine relaxation. The mother must sign an informed consent. And prior to the procedure, an ultrasound is going to be done to identify the location of the cord, the placenta, the fetus, and to look at the amniotic fluid volume. If you don't have enough fluid, you're not going to be able to successfully do this. A non-stress test will be done to confirm fetal well-being. Contraindications to doing a version would include uterine anomalies, any third trimester bleeding, multifetal pregnancy, so twins or trips, oligo, placental insufficiency, a nuchal cord, CPD, or any previous uterine surgery. Internal version, which isn't done very often anymore, is completed by the provider actually inserting a hand into the uterus and trying to reposition the fetus that way. Your induction of labor will occur for social or medical reasons. Even though people don't like to think social inductions are done, they are. If it's social, recommendations are to wait until a completed 39 weeks of pregnancy has occurred. If it's a medical induction, the timing of the induction is really dependent upon the risk to the mother and the fetus. A Bishop scoring is the system that's used to grade the cervix in regards to what potential success you're going to see with inducing the labor. A Bishop score looks at dilation, effacement, station, the cervical consistency, and the cervix position. It's about a 13-point scale. Typically, if you get a score of 8 or more, then the induction should be successful. And you got to think about, the more dilated the cervix is, the lower the fetus is, the engagement, the softer the cervix is, it's going to change better. So the higher your score, the higher your induction rate of success. Medical indications for inductions include things like IUGR, diabetes, hypertension, being postdates, and intrauterine fetal demise. Contraindications include bleeding, placenta previa, a floating presenting part, which means whatever it is, hopefully the head is nowhere near engagement, and severe fetal distress. Look on page 697 in your book and you'll see a full listing of indications and contraindications. The ones I've given you are the more common ones. When we're thinking about induction, to maybe help ripen or soften a cervix, prostaglandins such as dinoprostal or misoprostol will be used. Benefits to cervical ripening include less oxytocin for induction or augmentation of labor, so less exposure to the oxytocin. Now, misoprostol has been associated with an increased risk for tachysystole, so you see dinoprostal used more for the cervical ripening. Mechanical methods to ripen a cervix would include the Foley bulb. So you insert a Foley into the uterus, you inflate the balloon, and then pull it back against the cervix, and that actually puts tension on the cervix to help ripen it. Hydroscopic dilators and laminaria tents. An amniotomy is completed to either induce or it can augment labor. Risks when you do an amniotomy include prolapsed cord, infection, or really worst case scenario, hemorrhage if you hit a vasa previa and you rupture umbilical vessels. Synthetic oxytocin or Pitocin is utilized to either induce or augment labor. As we know, oxytocin is the hormone produced by the pituitary that stimulates uterine contractions. If for some reason the woman is not having adequate labor progress, think about your hypotonic pattern. If she's not in labor at all, we want to make her go into labor. She's ruptured, we want to induce the contractions. Then we can use oxytocin to get the ball rolling, so to speak. Oxytocin is a high-risk medication. Oxytocin administration in and of itself is not dangerous. The danger comes from not managing the oxytocin appropriately. If it's not being watched appropriately, you can increase the uterine reaction. You can elicit something called tachysystole, where there are more than 5 contractions in 10 minutes, averaged over a 30-minute window. If you've got too rapid of a contraction pattern, then you got to think about that uterus is constantly squeezing and it does not have a full relaxation time. It may not come down to a full soft resting tone. So you are promoting uterine ischemia and decreasing uteroplacental perfusion, which is going to lead to fetal distress. Oxytocin is always going to be administered through your IV line with induction or augmentation of labor. It's going to be a secondary medication. You're always going to have your main line open if you need it for intrauterine resuscitation or anything like that. The oxytocin gets mixed in to whatever fluid it's going in. Usually either saline or Ringer's, and it's going to be anywhere from 10, 20, or 30 units are going to go into 1,000 mLs of fluid. You're always going to infuse synthetic oxytocin through a pump. Remember, this is a high-risk drug, so you've got to really, really, really manage the dose administration of it. You're typically going to do 1 to 2 milliunits a minute. You're going to do 1 milliunit a minute. Start off. That's a low dose protocol. Start off, and then you're going to increase it 1 to 2. You need to give it at least. Your book says 30 to 60. I mean, generally 30 to 45 minutes is what you're going to need to look at before you increase it again. What you're wanting to do is to titrate it to an effective labor pattern. I don't know if you remember that we talked about MVUs. Go back and look at your fetal monitoring lecture. And those of you in clinical, go back and look at your fetal monitoring information that we did in our first week of clinical, where you talk about how to calculate your MVUs. But what you want is an MVU of 200 or more, usually 200, 220, because that typically is going to be indicative of a successful labor contraction pattern. If at any point in time in the administration of the oxytocin you notice tachysystole occurring, or you see what appears to be hypertonicity of the uterus, you don't come down to a soft resting tone, you see fetal distress, late decels, uteroplacental insufficiency, depending on what you see, what's going on, how severe it is, you're either going to cut your pit in half or you're going to cut your pit off. If you ever administer oxygen to your patient because of fetal distress, maternal distress, or anything, then you need to turn the pit off, because it's kind of counterproductive to try and give oxygen in the thoughts of you need to minimize hypoxia when you've got oxytocin going that is causing uterine contractions and thereby promoting hypoxia. So you don't use those two together. Now, we talked about induction of labor, but sometimes labor has to be augmented. Kind of like I mentioned in the previous slide, you may have a labor pattern that is moving along well, and then for some reason uterine activity maybe just stalls or slows down, doesn't look effective, and so you're going to need to augment that labor and try and get it going again so that you don't run into a labor dystocia. Well, there's different ways to augment labor. The exogenous oxytocin, synthetic oxytocin, Pitocin, that's pretty much your go-to kind of thing. You know it's going to have an effect. You're making it happen. You're stimulating the uterus. You should theoretically get labor moving again. If you want endogenous oxytocin, then the nipple stimulation is something you can do. Think about the CST that we learned about in the last lecture, where we have the woman do nipple stimulation to cause contractions. So you can try doing that. And then the amniotomy, which is the rupturing of the back of waters, that can, when the fetal head descends and comes down into, direct contact with the cervix, that can kind of help cervical change happen. You also get the pressure on the tissues in the pelvic floor. You get Ferguson's reflex, which is surge of endogenous oxytocin, which will stimulate the labor progress. Operative vaginal births occur when we need to help mom get the baby out. Maternal indications for doing this could be she had a prolonged second stage, so her pushing for whatever reason wasn't effective, and we need to shorten it because she could be wearing out, or she may have health issues, cardiac or respiratory issues, but she still has to be able to push for us to have an operative vaginal birth. Fetal indications could include fetal distress, certain abnormal presentations of the fetus, if there was an arrest of rotation and descent, or if we're trying to deliver the head when we've had a vaginal delivery of a breech presentation. With operative vaginal births, there's two routes. You have a forceps assisted and a vacuum assisted. The forceps, it's not forceps like a hemostat. It's actually, I kind of liken them to salad spoons that work together. They slide in on either side of the fetal head, and you don't squeeze. You've got to be very, very careful that you don't squeeze, but it just kind of helps guide the fetal head out and will let you deliver the baby. But mom still has to be able to push. In order to do a forceps delivery, for obvious reasons, she must be fully dilated. We don't want to have any trauma, lacerations, or anything. Bladder needs to be emptied. Obviously, the presenting part, the head, should be engaged. She's going to be ruptured so that we can determine exactly what we're grasping and where we're grasping it. And the maternal pelvis needs to be adequate to be able to do this process. When you use forceps, at delivery, the baby needs to be checked for, bruises or scratches where the blades or the forceps blades were applied, and needs to be checked because facial palsy resulting from pressure of the blades on the facial nerve can happen, and you also need to make sure that there is no potential or presence of a subdural hematoma. With your vacuum-assisted birth, it's not like a Hoover sucking the baby out or anything. It's just a little vacuum cup that is attached to the fetal head using negative pressure, and the suction, the provider is able to use that to kind of guide the fetal head out. There is a safety mechanism in place with this. It's a pop-off. If too much pressure retraction pressure is exerted by the provider, then the suction cap will pop off, is what we call it, and releases to try and prevent any damage with that. The provider gets 3 pop-offs. If we don't deliver successfully with 3 after 3 pop-offs, you cannot use it anymore. And when a vacuum is utilized in the labor process, every time there is a pop-off, it gets documented in the prenatal record. You also need to be sure that you assess the fetus or the neonate after birth, because if you remember when we're talking about our neonate, capits formed by the vacuum cup are not uncommon, but it can look pretty big, pretty bad, pretty gross, and parents can freak out about it. So you need to be able to identify if it's there, how big it is, and then you're going to watch for changes in it. To do a vaginal, operative vaginal birth, you need to have a vertex presentation. Again, she needs to be ruptured. Mom size, fetus size have to match up with each other, and she still has to be able to push. If you notice, I've said mom has to be able to push about 4 times. All right, so I heard this referred to as a vaginal bypass delivery. So cesarean births are an alternative birthing method. It's a surgical procedure. It is a transabdominal incision of the uterus. If it's necessary to deliver by cesarean in order to save the life of mom or baby, make sure that we have a good outcome, then that's what we're going to do. In 2006, 31% of live births were delivered by cesarean, which is a pretty high rate for a cesarean birth. We want to keep those down much lower than that. A woman who undergoes a cesarean birth may have a negative perception of her own birth experience. There are women who feel if they don't deliver vaginally that they did not have a normal birth process, and sometimes even that they failed in the birth process. But sometimes having a cesarean birth is out of their control. There's some things they can't make happen. They can't make it work right. When you're looking at identifiable risk factors, contributing factors for the needing of a cesarean birth, well, obviously, if you've got fetal macrosomia, if that is just too large of a fetus to fit through the pelvis, you don't want to run the risk of injury, trauma to mom or baby, so cesarean birth. Advanced maternal age, obesity. If she is of short stature, is short-waisted, that's an indication or contributing factor. Gestational diabetes, because she's going to be obese, possibly. The baby is going to be obese, okay, so that can do it. A multifetal pregnancy, you can try and deliver, like if you got twins, you can try and do a vag delivery with, I mean, they may both be head down, but after the delivery of the first fetus, it is not unusual for the second fetus to flip or change positions, do something, and you may have to do a cesarean birth on the second twin, even though the first twin was a vaginal delivery. And the unfortunate reality is malpractice is so high in OB that sometimes providers will opt for a cesarean birth just to be able to have as much control as possible over the whole labor and birth process and minimize any potential opportunity for malpractice issues to arise. If we do have to do a cesarean birth, you still need to follow all of the things that are necessary for a surgical procedure because it is a surgery. You may have an elective cesarean birth. Say if you've got a breech presentation, everybody's fine, baby's fine, mom's fine, it's just breech. It's going to have to come out by cesarean. If you have issues, if you have maternal distress or fetal distress for whatever reason, then you may be forced to have a cesarean birth. There are different approaches to the cesarean. You can do the Skin incision, it can be either horizontal or vertical. They're going to be lower on the abdomen. The fan and steel incision, that's the pretty classic one, kind of the quote-unquote bikini line cut. A vertical incision is pretty much what it says. It's up and down, but it's still in the lower abdomen. Internally into the uterus itself, you want to keep the incisions in the lower uterine segment because that's going to just passively stretch and dilate. You don't want it to go up into the body of the uterus where the contraction occurs. So the old-fashioned upper vertical incisions in the uterus, called the classical incision approach, if you had that, you don't get to do a VBAC or a trial of labor after a cesarean birth because of the potential for uterine rupture. Things that you have to think about whenever you're doing a cesarean birth. We rarely do general anesthesia anymore. It has to be a straight up, no holds barred, full-blown emergency to sleep a woman. So we usually will do spinals or epidurals for this. If you get a spinal or an epidural, you have to be careful about respiratory issues, especially with a spinal. If it's too high and you get paralysis of the diaphragm, then mom's going to have respiratory arrest. If you are sleeping her, then whatever you give her goes to the baby. So you've got about 60 seconds to get the baby out before there is the potential for neonatal compromise. You also run the risk of cutting the baby if it's truly an emergency. However, you got to stop and look at what you're dealing with. You may have a baby with a laceration that will heal, or you may have a baby that's dead. So which is going to be the worst case scenario here? If it's a scheduled cesarean birth, you've got time to plan for everything. You have to do the consents. You can have one person in there with her. As long as it's not general anesthesia, she can usually have somebody up at the head with her. If it's an unplanned cesarean birth, if she has to be put to sleep, nobody is allowed in the operating room. If she is awake, again, she can have one person. You still need to do the timeout the same way you do with any surgical procedure. She will go into PACU or recovery, even if she's awake. So if she had an epidural or spinal, she will still have to go through the full post-anesthesia care recovery period. And then after she has the baby, she's going to have ambulation concerns. We may be worried about DVT. So even though she had SCDs in the OR, still we need to get her up and ambulate her. We need to make sure that she's breathing. We need to make sure that she isn't having any nausea issues. We don't want her throwing up and having any aspiration issues or anything like that. A woman who has had a cesarean birth previously may subsequently become pregnant and not have any contraindications to labor or a vaginal birth in that pregnancy, and so she may want to do a vaginal birth after cesarean. We refer to this as a VBAC. You got to think about if she had a primary C-section and it was because of breech or in that pregnancy or in that labor there was fetal distress, maybe she had a labor dystocia. Typically you don't expect those things to happen again. So if it was something outside of her having a small pelvis or something like that, she may want to do a VBAC. 9% of women attempt a trial of labor after having a cesarean. So if they want to do a vaginal birth, we will let them try, okay? If at any point in time during that trial of labor, mom or fetus shows signs of distress, then we will stop the trial of labor and we will just do a repeat cesarean delivery. When you're trying to determine who is going to be candidates for a VBAC, ACOG has come up with some pretty specific selection criteria that they're going to go by. If she has one or two previous low transverse cesarean births, but no classical incision approaches, then she's probably going to be okay. They don't want to, if she's had 4 C-sections, even if it was a lower uterine segment incision, they don't really want her laboring, because you don't want to have that risk for uterine rupture. But if it's only been 1 or maybe 2, okay, then, her uterus may hold up to it. Is her pelvis adequate to be able to pass a fetus through? Has she had any previous uterine surgeries, not counting cesarean births, but, any incision into the uterus itself? Because that would negate her doing a trial of labor. And there has to be a physician readily available when a woman is doing a trial of labor for a VBAC, because in the event anything untoward happens, you've got to be able to act immediately, and that's pretty much going to be a cesarean birth. All right, so if we get a pregnancy that goes past the due date, past 40 weeks, then we are post-dates or post-term. You've got risk to both mom and to the baby. If you keep it in there for too long, then there's a good chance you're going to have a big baby. And so fetal macrosomia can indicate the need for a cesarean birth. It could also cause some maternal trauma if it's a vaginal delivery. And we're going to talk about it in our emergency lecture, but you can also have a shoulder dystocia. So bigger babies, increased risk for a dysfunctional labor pattern and trauma. Interventions are probably going to be necessary, so you may have to do the vaginal assisted delivery, and it can be pretty hard mentally and physically on mom. For the baby, again, a prolonged labor, because it's just going to take a while for that fetus to drop down and be pushed out. You can have the shoulder dystocia, birth trauma of the fetus itself. And then you also have to think about, if pregnancy is supposed to be 40 weeks, what happens when we start, going over that? If the placenta and everything is marked to go 40 weeks, well, if you start getting an aging placenta, you may have some concerns about ineffective placental perfusion. If you get calcifications, you may get infarcts in the placenta, so you're not going to have sufficient uteroplacental perfusion, and that's going to increase your risk for fetal distress when labor starts. All right, so sometimes pregnancies go past the due date. I had one of the OBs I work with told most new moms that on average, if you can expect to go to your due date and even into that first week after your due date before anything is going to happen. If a pregnancy gets to 42 weeks, that's considered a post-mature pregnancy. You start running into increased morbidity and mortality for the mother and for the fetus. Your placenta is aging, calcified, perfusion is going to be dropping down, your amniotic fluid volume is decreasing. We don't really want pregnancies to get to 42 weeks. Generally, inductions of labor will happen sometime between 41 and 42 weeks. Pretty much the standard that I've seen practice under is at 41 weeks, if the woman has not delivered, she will have a non-stress test or a biophysical profile done. If they do an NST, it's reactive, reassuring, then the provider is probably going to talk to the mom, and sometime within the next 2-3 days, they'll schedule an induction of labor. If they do an NST and it is not reactive, they may do a BPP. If they do a BPP and they see oligohydramnios, or if there's something distressing with the NST or the BPP, they'll just go ahead and induce labor then. They don't play around with it. So at the very least, they'll do an NST at 41 weeks. At the most, they will do an NST 1 or 2 times a week up into that 41 weeks. Generally, after they're not going to let a pregnancy go to 42 weeks because of the potential negative outcomes. All right, so meconium stained amniotic fluid. A lot of times we associate that with fetal distress, but it doesn't always have to be. When you see staining of the fluid, it's going to indicate to you that the fetus has, gone ahead and passed, meconium, first stool, at some point in time before delivery, okay? Typically, the amniotic fluid is going to be greenish in color. We describe it as either thick or thin, really depending on how much meconium is in there. If the neonate, if skin and nails are like stained that greenish yellow, then the meconium has probably been in there for a while. But if, everything washes off, rinses off, the, neonate has normal skin color and everything, it could have been what we call a terminal passage, which is just at the very end of the labor and birth process. Typically, you're going to have 3 reasons for meconium passage and then staining of the amniotic fluid. It could just be a normal function of fetal maturity. You may also see it with a breech presentation, depending on how the contractions are, kind of just, I guess, squeezing against the fetus. You may have the meconium passage then. It can be a result of hypoxia-induced peristalsis and sphincter relaxation, or it may be a sequel to umbilical cord compression-induced vagal stimulation in mature fetuses. The one thing that you really need to worry about if you have a MEC delivery is the possibility of meconium aspiration syndrome, which is a pretty big risk for your neonate because they can have aspiration pneumonia. If you are in a meconium delivery, according to current NRP guidelines, you don't suction the neonate if it's vigorous. If that baby is moving, if it's trying to cry, if it's got good tone, let the baby clear it itself. Because if you try and suction it, you may actually push meconium down further into the respiratory tree, or you can cause vagal stimulation, or you may force the baby to suck it down further. Now, if you have meconium aspiration and you have a limp baby, then definitely, according to NRP guidelines, you do want to go ahead and you want to suction that baby. You'll actually put an ET tube down, you'll put the suction down the ET tube, and you will withdraw the suction catheter and the ET tube at one time, and you just do the suctioning once. All right, so most of you, except for this last group that I've got this week, have come through clinical, and at some point in time, we may have talked about the shoulder dystocia when we were in the sim lab. Shoulder dystocia is when the head is born, but the anterior shoulder just can't pass under the pubic arch, so it's stuck. If you have a fetal macrosomia, that's going to be one of the most common causes of it, or if you got too small of a maternal pelvis to be able to let the fetus pass through. The neonate is likely to experience some birth injuries from this. Now, it may be soft tissue bruising all the way up to a broken collarbone, a dislocated shoulder. You may even have fracturing of ribs and a pneumothorax if you have damage under the soft tissue. Mother's risk is going to be associated with increased risk for hemorrhage, trauma to the birth canal, the cervix, the vagina, could need an episiotomy, which can extend into, a 3rd and 4th degree tear, and she can even get an infection. There are a number of different interventions or, quote, maneuvers that have been suggested to free the anterior shoulder. One of the first things that we're going to do is something called McRoberts maneuver, where we're really trying to open the pelvis up. So we are going to, have her flexed at the knees, flexed at the hips, and we're going to bring her knees up and kind of back and out to try and open that pelvis up. And then we're going to do suprapubic pressure to try and reduce that shoulder and try and deliver it under the symphysis pubis. If neither of those two things work, the provider may run his hand up inside along the fetal back, find the arm, kind of cross the arm over the neck and try and reduce the shoulder that way. They'll try to rotate the arm up so that it's over the head, so that it just kind of makes one straight line. We can reduce that way. And if none of those things work, then the provider may actually break the collarbone, and that will drop the shoulder in and of itself right there. All of that sounds really harsh, but you've got 5 minutes in a shoulder dystocia to deliver the baby. It is an OB emergency. You have a recorder, just like if you were doing a code situation, and you've got a scribe who's writing down the time that any meds were done, any interventions were done, shocks, defibrillations are done. In a shoulder dystocia, you have the same thing because it is a true emergency. Another OB emergency that we have to deal with is a prolapsed umbilical cord. This is when the fetus is up high and the cord is below the presenting part of the fetus. Now, it can be described as two different ways. An occult prolapse cord is one that's hidden. So that means the cord itself doesn't protrude through the cervix and into the vagina. It is up inside the uterus. So it's still below the presenting part, but we don't see it. A frank cord prolapse is just the opposite, where it is out and we can either see it at the cervix, we can see it in the vagina, or it may actually be protruding out the introitus and exposed outside of mother. Regardless of how it's classified, a prolapse cord is an OB emergency. Things that contribute to the possibility of a cord prolapse: if you have a long cord, that's not a very, very common thing, but it stands to reason that if you've got one that's longer than 100 centimeters, there's a possibility that some of the cord's going to come out. An unengaged presenting part, especially in conjunction with artificial rupture of membranes, you got to think about if you've got a fetus that's high up out of the pelvis, so say at a -3 or above station, and the bag of water breaks, whether spontaneous or artificial, as the fluid rushes out, there's nothing of the baby that's down low enough to block the exit. So the fluid rushing out is actually going to pull the cord with it. So that's how you have a prolapsed cord, with a malpresentation being, a breach so that the head's not blocking the way, or if the baby's high up out of the pelvis. Really, you're just going to have to make sure that you see this as soon as possible. So prompt recognition and intervention is going to be critical to a successful and positive outcome. What you're going to need to do is relieve pressure on the cord. So whatever the presenting part is, you're literally going to have to put your hand up in the vagina, and you're going to have to lift that presenting part up off of the cord. So you may only be able to use 2 or 3 fingers to hold whatever that is up, and once you're there, you don't move. Okay, you are there until delivery of the baby. You need to be sure that you are not touching the cord in any way and manipulating it, because that can cause vascular spasm in the umbilical vessels, which is not going to be a good thing. Generally, management of the cord is going to be done with laying a sterile towel over it and then wetting it with sterile saline. But you don't want to then mess with the cord. So you, as the nurse, with your hand holding the presenting part up off of the cord, are going to be in the bed with mom, and you are going to stay in the bed with mom. You're probably going to get onto the OR table with mom. You're going to be draped under the drapes with mom, and until you feel the provider lifting the fetus out through a cesarean incision, you're going to stay right there with mom. If you have a woman who is in a cord prolapse situation, you can put her in a modified Sims position, elevating the hips as high up as you can, or you can put her in a knee chest position. I personally have never seen either of those, but that doesn't mean it's not done. It's just because thankfully cord prolapses are not not a high common thing to have happen. It stands to reason that a uterine rupture is a pretty significant OB emergency and injury. Okay, things that contribute to the possibility of uterine rupture will be a trial of labor for a VBAC. You know, we talked about cesarean births just a few slides back, and there are definite criteria that the woman has to meet to be allowed to do a trial of labor after she's had a cesarean. So if, you know, her previous cesarean was a classical approach and the incision was not lower uterine segment but actually the body of the uterus, that person is not going to be a good candidate, and so she is at increased risk for uterine rupture. Using oxytocin to induce or augment labor. If you promote tachysystole, so that uterus is contracting too much, too fast, and you don't allow it to come back to a soft resting tone to fill up with blood, that's a worry. You got to think about the uterus is a muscle, and that muscle needs to be perfused the same way that the fetus needs to be perfused. If you have any congenital uterine anomalies, maybe a bicornuate uterus or a weak spot, then that's going to put them at risk for uterine rupture. Any previous uterine surgery, maybe they've had fibroid removed, they've had myomectomies done, that's going to be an increased risk for uterine rupture, along with your multiparities, multips, grand multips, and any type of previous uterine trauma. So what you're going to see in the individual with uterine rupture is really going to kind of vary depending on how bad the rupture is. A woman with a uterine rupture, you would think you would see bleeding, hemorrhage. She would have abdominal pain, pretty intense. She may have a rigid abdomen. If she's laboring, then you're probably going to see pretty immediate responses in the fetal heart rate pattern that's going to be reflective of fetal hypoxia and fetal distress. If she is hemorrhaging, you know, tachycardia, because body's trying to compensate, you may start seeing neurologic changes. All of these may almost seem like normal progression of labor patterns from stress and everything, but again, the blood and just the changing of the abdomen and the increased abdominal girth, those are going to be things that you're going to be looking for. Management of this really is dependent upon the severity. It's almost always going to be a surgical intervention, but to what degree? I mean, you're going to have to repair the rupture. If it's small enough, you can repair it and save the integrity of the uterus itself. However, if it is a severe rupture, maybe, you know, blows out a section of the muscle wall, a hysterectomy may be your only recourse of action. And then the last OB emergency that we're going to talk about and finish the chapter up with is our amniotic fluid embolism, or AFE, and this is sometimes referred to as an anaphylactoid syndrome of pregnancy. AFVs are not very common, but when they happen, they are a significant and devastating complication of pregnancy. What you're typically going to see is a sudden onset, hypoxia, hypotension, cardiac arrest, and coagulopathies. Generally, your AFVs are going to come on during labor, birth, or sometime within the 30 minutes immediately after birth. And pretty much what you're going to expect to see is the foreign substance introduced into the circulation. The foreign substance is going to be all of the debris from the amniotic fluid, you know, the vernix, the hair, skin, meconium, any of those things can enter into mom's circulation. So you're going to see some pretty significant pathophysiologic events. And it's going to look like sepsis or anaphylaxis, which is where the anaphylactoid syndrome of pregnancy concept comes in. Even though amniotic fluid emboli are not common occurrences, when it does happen, it's significant. The mortality rate's about 61% or more. And approximately 50% of neonates who survive an AFE delivery will have neurologic impairment. If an AFE occurs, CPR is almost always going to be necessary. If it's unsuccessful and she has cardiopulmonary arrest, for optimizing fetal survival to have the best neonatal outcome that you can, you may have to do a perimortem C-section. You've got about 5 minutes to get that baby out. If she survives, if you do CPR and it's effective, she's probably going to be, she will be critical. She'll need to go into an intensive care unit. She may need to have blood volume replaced, clotting factors. She's going to have to be hydrated, may need vasopressors to keep her blood pressure up so that she's perfusing well. It's not unusual that she has to go on a vent. You know, the family is going to be left alert for all of this, and so they're going to need support whether the mother survives or not. You know, everybody's going to ask why, and you don't always have the answers. You can't tell the whys of it. So you want to keep them as informed as possible. If you do have maternal and or neonatal loss, then a referral to grief and loss support groups, you know, could very well be necessary and would be appropriate for this. And it's hard for you as nurses to have to deal with loss, especially, you know, neonatal loss is always hard, but when you lose the mother and the baby and you know, see the family struggling with this, that can be very challenging on nurses as well. So there may be the need for nurses to have some kind of support system and support groups in place as well. If you look on page 720, in your book, you will see the little emergency box that talks about amniotic fluid embolism and you know, the different signs to watch for and what the nursing intervention should be. So that wraps up chapter 22, labor and birth at risk.